Hello, my name is Scott Register, and today I'll be discussing the Hospital Readmission Reduction Program as it relates to penalties. I'll begin by providing some history for how this piece of legislation actually came into being. In 1965, Congress passed Title 18 of the Social Security Amendment of 1965, creating Medicare. There were two parts, Medicare Part A and Medicare Part B. Medicare Part A provides hospital care coverage for the elderly in addition to partial coverage for nursing home care. Part B, created to cover physicians' bills, is supplementary medical insurance partly funded by tax revenues, with the remaining portion being covered by the insured through premiums. I'm 42 years old, and for as long as I can remember, there's been seemingly endless debates over how to lower Medicare spending while at the same time preserving the level of care participants in the program received. Evidence can be found practically any given week in a newspaper, or on television or radio news programs, various organizational research, etc., to this effect. Graphically shown in this slide is the solvency projections of the Medicare Part A Trust Fund from 1970 until 2013. From the data shown here, it is understandable that there would be a great deal of debate regarding the future of Medicare and the best course of action to protect it. On March 23, 2010, President Barack Obama signed into law the Patient Protection and Affordable Care Act, also known as the Affordable Care Act or Obamacare. The Affordable Care Act can also be described by its acronym ACA. According to and like President Obama, those who enacted this legislation were motivated by strengthening Medicare through lowering costs, allowing for solvency while at the same time improving the quality of the care provided to Medicare patients. With these measures in place, the expansion of health insurance coverage could hopefully be ensured. The promise by those touting this law was that 32 million uninsured Americans would be able to, by this legislation, obtain affordable health care. Healthcare reform, brought about by enacting the Affordable Care Act, is expected to lower costs to Medicare through improved care, which is a major goal of the Obama administration. Further, the Obama administration has instituted a number of reforms to attack the issue, and in so doing this, it will conceivably save as much as $60 billion for taxpayers through 2016. One program implemented to aid in lowering the cost is the Hospital Readmission Reduction Program. In addition to lowering cost, it seeks to improve quality of care. The idea behind the Hospital Readmission Reduction Program is that patients who are discharged from the hospital are done so once their health status has achieved a level conducive for continued care at home or in a setting that provides a lower acuity of care, such as a rehab facility. So essentially, the government is shifting away from fee-for-service to paying for outcomes under pay for performance. Back in 2005, there was an analysis performed on Medicare claims data by the Medicare Payment Advisory Commission, also known as MedPAC. This commission, this analysis showed that 75% of readmissions within 30 days of discharge could have potentially been prevented. The cost incurred to Medicare by these readmissions was estimated to be $12 billion. There are numerous reasons why readmissions may occur: the patient's diagnoses, severity of illness, patient's ability to understand and follow discharge instructions, their willingness to even adhere to the discharge instructions, and the availability, quality, and accessibility of care after discharge. Furthermore, the American College of Emergency Physicians website states that current statistics show that 20% of Medicare recipients who were admitted into the hospital experienced a readmission within 30 days of discharge. To aid in solving this issue, Section 3025 of the Affordable Care Act charged the Secretary of the Department of Health and Human Services to develop and implement the Hospital Readmissions Reduction Program. Starting on October 1st, 2012, this program decreases the amount of payments due to high readmission rates. This applies to subsection D hospitals, which, per the Social Security Act, is defined as short-term inpatient acute care hospitals paid through the Inpatient Prospective Payment System, or IPPS. There are some exclusions. These exclusions include critical access hospitals, psychiatric hospitals, rehabilitation facilities, long-term care facilities, children's hospitals, and cancer hospitals. The reduction in DRG payments will be based upon the hospital's ratio of actual to expected readmissions. In other words, the severity of the penalty varies with the amount of readmissions within the 30-day period. It's important to note here that it's not just the Medicare payments for the measured clinical conditions, and those clinical conditions that's spoken of here are three of them: heart failure, acute myocardial infarction, and pneumonia. I'll discuss those in a bit. It's all Medicare revenues for the fiscal year that's actually reduced by the applicable percentage for that year. There are some exclusions that apply, such as transfers to another acute care hospital, some readmissions that aren't related to the prior discharge, and some planned readmissions for procedures related to an acute myocardial infarction measure. The Centers for Medicare and Medicaid Services, or CMS, will continue to reassess the exclusions from the calculation for readmission penalties. The National Quality Forum, or NQF, is a not-for-profit membership organization. Its mission is to develop and implement a national strategy for healthcare quality measurement reporting. The Affordable Care Act states that the Secretary of the Department of Health and Human Services is required to adopt measures otherwise known as the 30-day risk standardized readmission measures, which is endorsed by the NQF. For fiscal year 2013, there were three measures. These were acute myocardial infarction, heart failure, and pneumonia. These are the ones that I alluded to earlier. For fiscal year 2015, there will be an expansion in the number of measures to include chronic obstructive pulmonary disease, coronary artery bypass graft, and percutaneous transluminal coronary angioplasty, and other vascular-related diagnoses or procedures identified by MedPAC. Additionally, affected hospitals will be mandated to report all pertinent hospital-specific all-payer readmission rates. This data will be provided to the public through Hospital Compare, and that's a U.S. government website which allows the consumer to actually compare HCAHPS, or HCAHPS scores are basically your patient satisfaction scores, and the acronym HCAHPS, HCAHPS, actually stands for Hospital Consumer Assessment of Healthcare Providers and Systems. So, as stated before, the CMS currently calculates a hospital's excess readmission ratio for AMI, or acute myocardial infarction, heart failure, and pneumonia, and compares this to the national average for hospitals with the same applicable condition. It includes clinically relevant criteria such as the patient's demographic characteristics, comorbidities, and the patient and patient frailty. And comorbidities is basically the existence of two or more diseases at the same time in a patient. Race and socioeconomic backgrounds were excluded from the calculation. Lastly, CMS gathered discharge data from 3 previous years, utilizing at least 25 cases for each of these applicable conditions, myocardial infarction, heart failure, and pneumonia, and inserted it into their formulas to calculate the hospital's excess readmission ratio for each of these applicable conditions. So, as an example, a hospital that has been assessed a penalty of 1%, if they have a Medicare reimbursement equal to, say, $50 million, then their penalty will be 1% of the $50 million, or $500,000. So for that year, the amount of reimbursement that they will receive is $49.5 million. It doesn't seem like a huge amount, $500,000 compared to $50 million, but when you consider the tight budgets under which these organizations are now having to operate, it makes a tremendous difference. On August 13, 2012, the National Public Radio Service, or NPR, reported that for fiscal year 2013, 2,011 hospitals would have their reimbursements cut by up to 1%. Further, and what I found very interesting was that they stated that the Massachusetts General Hospital in Boston, Massachusetts, which was celebrated as the best hospital in the country at that time, paid 0.5% of their base Medicare reimbursements for excess readmissions within 30 days of discharge. And this is the best hospital in the country. 278 hospitals in the country had theirs cut by the max of 1%. Obviously, those hospitals that reside in the poorest regions of the country will be hurt the most, and the reason being is because they'll be paying the maximum 1% every year. And it has to do with the demographics of the patient. Additionally, the percentage held back increases each year by 1%, according to the American College of Emergency Physicians website. So I put a graph here, or the table rather, and this table shows that in 2013 the penalty was 1%, and in 2014, this year, it will be 2%, and in fiscal year 2015, it'll max out at 3% for all successive years moving forward. So, although it's not been easy to tackle this issue, hospitals have no choice but to develop and implement strategic initiatives aimed at reducing the number of preventable readmissions within 30 days of discharge. Otherwise, they'll find themselves at a dramatic, fiscal disadvantage. This may all seem a bit unfair that the government would hold back money that was already earned by these hospitals and make them earn it a second time, basically. But the federal government, if we all look at this from a common sense standpoint, the federal government has to do something in order to provide incentives that would make the hospitals take the initiative to improve the quality of care, as well as reduce costs. Under the fee-for-service system, hospitals and physicians benefited from these readmissions. Under the new rules set up through the Affordable Care Act, this is no longer going to be the case, that they'll be able to benefit from these readmissions without having to pay some sort of a penalty, obviously. So how does this affect hospitals? Budgets that are already pushed to the extreme will get even tighter if they don't find a way to innovate in order to reduce potentially preventable readmissions. This may mean that the number of services provided by the hospital in question may be reduced. It may also mean that, along with other measures introduced in the ACA, a reduction in payroll and/or workforce may be required to survive cuts. And so how does this affect patients? Well, patients may find fewer services. So, the number of services that are currently available to them may not be there under this new system, which means there may be a decrease in access overall. But the quality of care should improve with better outcomes as a result of more focus on quality measures by CMS. At least I think that's what the government's hopes are. I personally also hope that as well. This concludes my presentation. Thank you for watching.